The symposium around building a more equitable health system for all will be moderated by Dr. David Nash, founding Dean Emeritus of Jefferson College of Population Health.
Well, it's so great to be here for the first virtual, but the 5th annual International Vatican Conference. And I'm here with some outstanding friends from all around the world. What a great opportunity. My only wish is that we could all be physically together, but next time we'll be in Rome together. So I'm here today with Dr. Paul Farmer of Partners in Health, Dr. Walter Ricciardi of the World Federation of Public Health Associations, and Dr. Chelsea Clinton of the Clinton Foundation. Welcome, colleagues. Great to have you with me. Our topic today couldn't be more timely, right? Building a more equitable health system for all. My goodness, what the world has been through in the past year and a half almost, and what's happening right now in different parts of the globe. I couldn't think of a better team to put together for this amazing meeting to tackle how do we build a more equitable healthcare system. So let me start with Paul Farmer. Paul, you have been all over the world multiple times. Your work with AIDS, your work in Haiti, your work in Sierra Leone, my goodness. So if you had to distill some of the take-home messages for our global audience, even from your most recent trip as it relates to building a more equitable system, what would you advise our colleagues from around the world?
Well, first of all, thanks so much for letting me be part of this, David, and all of you who organized this. I just got back from Sierra Leone, and I'm still in transit, and I just want to give that as an example of lessons learned, hard lessons. I never set foot in the place until 2014 when it became clear there was a major Ebola epidemic, and one for which that region was uniquely ill-prepared. They didn't have the staff they needed after the war, the Civil War. A lot of people know about the Blood Diamond War. Didn't have the stuff they needed, the supplies, didn't have the space. A lot of hospitals and clinics had been destroyed during the war. They didn't have the systems. And so, too, was the case in Liberia and to a lesser but important extent in Guinea. So that region, had to learn the hard way about things like social distancing, mask wearing, contact precautions, PPE,
wow.
And later how to roll out a vaccine. So I think a lot of the lessons that we've learned in some of these settings that seem so different from Italy or the United States are important ones. And when you think about Rwanda and what it's managed, then you can find a lot of very good lessons, not just for Sierra Leone and Liberia, but also for the United States. And I'm sure Chelsea and others will have something to say about those lessons as well.
Great. And we're going to come back to your experience as well, Paul. Thank you so much. Well, Walter, great to see you. Great to be together. My goodness, Italy has been sort of the test bed for the whole world, what you went through a year ago now, how you've recovered. So I guess it's sort of a similar question that I asked Paul. Can you distill for our global audience, what were some of the take-home messages that you and your colleagues learned and through the suffering that Italy just recently went through?
Yeah, we had to take very tough decision in a short time. I cannot forget when we invited all the ministers of health of the neighboring countries in Rome to explain that we were going to lock down the country. So for the first time in the modern history, that an entire country of 60 million people was locked down for 2 months. And this decision that I still remember the face. They couldn't believe it. And they immediately thought that they were going to do the same in their own country. And at that time was unimaginable. But that was a decision that we took to protect the South. Because as you may remember, the epidemic started in the North, which is much richer and much better equipped, and was a disaster. We couldn't imagine if the epidemics could strike the south of Italy. And in fact, afterwards, this decision saves approximately 40,000 lives in the south. So that was really really difficult to take this decision. Unfortunately, I must say that the lessons was not learned, because whenever summer came, everybody forgot it, and they tried to reopen it, everything, and the second wave strike, and the third wave strike, and now all the country. Now, of course, we have to protect the poorer. In a country like Italy, where we have a national service, is not a problem of geographical distribution, is a problem of socioeconomic, and geographical. And we have to manage like this. And I hope that in the future we take a memory of this lesson.
Wow. Well, I hope we'll be able to draw on that globally, Walter, and we'll come back to you about some of the additional lessons. And I can't help but mention the special relationship between Jefferson Health in Philadelphia and your amazing organization in Rome. You served as an early warning system for our physicians who were in touch with you Christmas time a year ago, and they said, be careful, here's what's coming. We were lucky to have your help, and something I know that my clinical colleagues will always be grateful for. Well, speaking of grateful, amazing to have Chelsea Clinton here. Thank you too for joining us. The work of the Clinton Foundation. So you're probably the best person to address these public-private partnerships. What do you see the role of the foundation and the learnings that you've been able to garner from this dreadful year we've all had?
Well, thank you, David, and thank you to the Vatican for convening us virtually. I want to acknowledge that this still is very much an awful time that so much of the world is living through. And I think it is important that we recognize that we are still very much in this together, albeit while, here in the United States, we continue to vaccinate, on average about 3 million people a day. Our experience at home is diverging rather rapidly from so much of what the world is continuing to endure. And that not only do we have a responsibility, I think, a moral urgency to try to help alleviate suffering around the world, it also very much is in our own economic security and public health self-interest. And so, just your question about public-private partnerships, my father started the Clinton Foundation 20 years ago, really in reaction to another yawning, growing, and indefensible health inequity that HIV positive people here in the United States and Italy and much of the Western wealthier world were able to access life-saving medicines, and so much of the world who weren't in those wealthier geographies were not able to. And so he started the foundation to really change the antiretroviral market from one that was a high price, low volume dynamic to a high volume, low price dynamic. And we proved, as Paul had been saying for many years, even by that point, 2 decades ago, that when people have access to medicines that will save their lives, they will take them. There will be good adherence. People want to live. People want to be able to be there for their children, their grandchildren. People want to be able to work and to thrive. And so I find it quite painful, David, at this moment that there is this posture of, well, if we have TRIPS waivers, which are important to help democratize and unlock access to the mRNA technologies that we know have been so powerful for the COVID-19 vaccines. Like if we do that, vaccine manufacturers won't be able to make them. Or if we do it, how do we know that they'll be able to be distributed? Or if they're distributed, how do we know people are going to line up to take them? Well, we know because we've been to this dance before. And so right now, to your question of public-private partnerships, I think we have an urgent need for the largest public-private partnerships that we would have ever seen across the globe to really rapidly scale up vaccine manufacturing and distribution around the world, because it's just inexcusable that we aren't already doing everything that we know could work to be able to do that.
Well, so heartfelt, Chelsea. And as we're here today, of course, what's going on in India and in Brazil, And of course, this group embraces the fact that we're only going to be safe here when we're safe everywhere. And that is the key message. And we'll come back to you more and talk about misinformation and what's limiting vaccination. I mean, incredible. And we appreciate, of course, at this conference that 16% of the world's population owns more than half of all the doses. So a very small percentage of the globe's total population is driving all the ownership. And we can talk a lot about reducing hoarding, reducing the limits on the patents. I mean, there are things that definitely can be done. Well, Paul, back to you. So again, in your experience, let's talk about Rwanda. Are there specific references and specific stories that you think we can message better, especially given the current crisis?
Well, first of all, that's exactly, the place that was on my mind as we were speaking. Since we've been summoned by the Vatican, and I have to admit, I get a personal charge out of that, being Catholic. I just want to go to some language that wasn't really used in Rwanda, but is rooted in Catholic theology and Catholic social teachings, and that's the idea of a preferential option for the poor. In other words, I'm not a theologian, but the idea being, God loves everybody and is fully capable of it, but particularly the poor. And pathogens and pathogenic forces, pathogens like COVID, pathogens like Ebola, pathogenic forces like racism, gender inequality, they also make a preferential option for the poor. So why don't we in medicine and public health say, yeah, we're here for everybody, but we're particularly there for them? And what the Rwandans did was not to use that language, which really emerged largely from Catholics in Latin America. And I hope to see it taken up everywhere. Certainly, Francis has embraced it. But what the language they used was right out of development economics. And they said, we're going to focus on the bottom quintile. That means, the poorest fifth. And we're going to focus on the rural over the urban, and the widow and the child and the genocide survivor, And so this language was different and well suited. Chelsea has been there quite a bit as well and worked with the Rwandan authorities, as have I, for many years. But the effect was the same. That is, by focusing on the most vulnerable, all of the rollouts for everything from AIDS treatment, tuberculosis detection and treatment of stunting, a number of initiatives that were rolled out through the public care delivery system, they were targeted on those who would benefit the most, which is the most vulnerable. And I think that's a lesson, that we need right now. I know we'll get into the question of vaccine hesitancy, which is a very complex issue and not a simple one. But, when you're visibly serving, certainly as a clinician, when you're visibly serving those in greatest need, they may be the sickest, they may be the poorest, but somehow they're the most vulnerable. That generates trust. And I think that's what you see in Rwanda, is a great deal of trust in the public health care delivery system that, we sorely need in the United States. I don't know about Italy, but, and in many places in the world, it would be great to have that kind of trust.
Well, Paul, your experience from Rwanda has direct application to the great city of Philadelphia, right? Where 1/4 of our population lives in poverty, and a city with 5 academic medical centers, we still do not such a great job of reaching out to the communities that need us the most, because our system is focused on healthcare service, not on improving health. And so what a great example you've set, and we could bring those lessons from Rwanda right to Philadelphia. No question about that. Well, Walter, back to you. I know that you've also led through your global work with the Federation of Public Health Associations all over the world, and we were supposed to be together in October in Rome. The use of big data, could you tell us a little bit more about that, especially in the Italian experience as you were tracking the progress of the pandemic? How did you and your colleagues organize the data, share the data, And are there lessons that we could learn from the organizing that big data?
I think that, and the pandemic has confirmed this, having good doctors is, of course, the most important prerequisite. I mean, human resources are really important, but management has become important as well, because the organization of healthcare is so complex, and the pandemic has put in danger millions of, for instance, oncological patients. I mean, only in Italy, we have lost 2 million oncological visits, and 3 million of oncological screening. So this means that we have to catch up. And to catch up, of course, it's very important that you base your decision on data, on solid evidence. And with this, you can help to target the precise part of the population that needs more. With this, you can target the prioritization of resources. With this, you can take the decision that do not harm a substantial part of the population, privileging the one that are needing most, So essentially, but for this, we haven't enough data, and moreover, we haven't enough expertise. Now, essentially, it's very difficult, because when we speak about big data, we speak about millions and millions of data. And this is not very easy to do. And in Europe, it's also particularly difficult because of the attitude of member states to protect, which of course is very important, the privacy of people. So you have to find a new balance. And now in Europe, there is a big discussion on this. So reforming the global, the protection data regulations in order to do that. I think we are just at the beginning of a new journey in which we will regularly use big data for taking our decisions.
Wow. And I hope we'll be able to share that worldwide, right? That would be a great outcome from this. If we could learn and share that data and our experiences in the US with yours, Rwanda, and everywhere, that's obviously very, very important. Well, and also, Walter, I think you brought up an important point. We have clinicians who have coined the term the pan-didn't, meaning the people who didn't get care who needed it. And at Jefferson Health, our 14 hospitals, we're seeing unbelievable backlog in folks who have missed all of their preventive care. And we're really encouraging people to get back to it, because that's actually how you start to improve health. It's incredible. Well, Chelsea, back to you.
And David, I was just going to say, I also don't want to lose the focus on children's well-child visits as well. And I don't know kind of what it is in Italy, but, here in the United States, it's just not hyperbole to say that actually tens of millions of well-child visits were skipped or lost, kind of whatever the most appropriate framing is, over the last 14 months. And so we also need to focus on, a class that is especially vulnerable, our kids, to ensure that we're catching up kids too, to get their routine inoculations, to get their routine blood lead level screenings, and just so much else. So I didn't want to, I'm so sorry for interrupting, but I didn't want to miss including kids in kind of the really, I think, helpful framing of.
Really great point. And all the talk about vaccinations, we can't overlook the critical ones that are also central to getting back to opening school, right? Really, really important. Well, Chelsea, earlier we just touched on the notion of, vaccine misinformation, vaccine lack of confidence, vaccine hesitancy. I mean, what's happening at the Clinton Foundation? How are you helping to focus on the fact that still millions of Americans, millions of educated folks still don't want to get a vaccine, something that is so vexing to a group like this? Can you shed some light on that for us?
Yeah, thank you, David. I mean, we are doing a lot to try to help both ameliorate and respond to hesitancy, as well as to help reach out to people who are kind of currently in vaccine refusal. And I do think it's important to disaggregate those groups. So there's people who are hesitant because they have lots of questions about the speed at which these vaccines were apparently developed, and so they're worried were steps skipped. Questions about kind of what's gone into the vaccines. Do we really have kind of confidence in the integrity of the ingredients. Admittedly, also some kind of conspiracy theories around, are there microchips kind of embedded in the vaccines? Kind of, is this some plan for the government to, or some other authority to kind of track individuals? And so, there are kind of those sorts of questions, which I think, are very much on a spectrum, and yet kind of which have very real answers to them. And then there are the people who are kind of in the refusal group right now, who just don't think it's relevant to them. Often young people who just say, no, like, I'm not interested. If I get COVID, it's not going to be a big deal, which I think highlights another kind of failure of public health communication in this country. Or who think like, maybe in a couple of years when I just know more, you can't tell me that we really know enough. I'm not persuadable. So I do think, we just have to be, cognizant that there are kind of very different reasons why people may say, not now or not ever. And then, of course, there are kind of people who have been themselves, or kind of are part of communities that have kind of been mistreated, maltreated kind of by our healthcare system for generations. So, kind of how we address vaccine hesitancy in incarcerated settings has to be different than how we think about that in non kind of incarcerated settings. How we talk to kind of Black Americans, Indigenous Americans, Latinos, who kind of know that members of their communities have often been mistreated or even kind of manipulated and exploited by our healthcare system. So, I think kind of we try at the foundation to really help equip trusted messengers, whether in healthcare settings or not. We've done work with a number of different religious communities, including some of our Catholic partners, to really help ensure that kind of whomever is able to have a conversation really is able to preempt or to answer whatever questions people may have. And even for those who are currently in the refusing kind of group, to kind of message like the vaccines are waiting for you, and the vaccinators will be too, whenever kind of you are comfortable, and we are going to keep reaching out to try to help you get comfortable. So we're just doing everything and anything we can, as I think so many of us are in this moment. And then we're increasingly thinking about how we can engage in this work globally too, because unfortunately vaccine hesitancy and vaccine refusal are not just uniquely American challenges. And then the last thing I'll say, David, is just on a personal level. So kind of just need to be clear, this is me just speaking, as Chelsea, and not kind of with the Clinton Foundation or with the Clinton Health Access Initiative, is that I personally very strongly believe there has to be more intensive and intentional and coordinated global regulation of the content on social media platforms.
Totally.
We know that the most popular video across all of Latin America for the last few weeks, that now has tens of millions of views, is just an anti-vaccine, kind of anti-science screed that YouTube has just refused to take down. We know that often anti-vaccine content that is created in the United States, unfortunately, kind of flourishes across the world, kind of, through the pathways of WhatsApp, Facebook, Instagram. And we know that kind of, because I have tried appealing to kind of the leadership of these companies to do the right thing, has just not worked. And so we need regulation.
Well, I'm very glad you brought that up. And I hope that with your influence and the influence of the foundation, you'll continue to fight that. And I heard, I think, two key messages from you, which is different messages for different groups, both domestically and internationally. And to think that one message is going to convince everybody, obviously very naive. And in our great city of Philadelphia, boy, your take homes are still very apt. Okay, well, watching the time, we have time for one more big important question talking about the future. We'll go in the same order. So here's the question. If we had to build the equitable healthcare system of the future in our own great country, what do you think the key attributes of that system, if you had the opportunity to participate directly in building this system of the future? So Paul, then Walter, and we'll end with Chelsea. What would this equitable system of the future look like? Please.
I kind of wish that you had started with the others because they're better at the policy questions. But just in terms of fantasizing, I can say, David, that it would not be a fee-for-service system.
You bet.
It would have a safety net that was unstinting and did not leave people out. It would focus on the burden of disease. Where does that burden lie most heavily? Again, there's a Rwandan way of doing that. There certainly can be an American way of doing that. It would look very critically at gaps. After looking at the burden of disease, it would look at gaps. What is not being addressed? And I think there's some heartening signs from the new U.S. administration that is fueling some of their thinking as well, the burden of disease and the gaps. And then, just because we're in the middle of a pandemic, and I would just point out that even right down to the technical level of how do we vaccinate.
Yep.
Those are very useful ideas, like and to be Catholic about it with this lowercase c, meaning universal.
Right.
The same way of thinking: safety nets, burden of disease, go where the gaps are, and above all, what people are looking for when they're ill is not more disease control, but care, but expert mercy. It has to be, this system has to not ignore those who are already critically ill or injured. Because some of the progressive or self-declared progressive groups are saying we have to focus on the social determinants of disease. Yes, of course we do, but we can never leave out the elderly, the frail, the infirm, the injured. And I've seen that happen way too many times in the response to epidemic. It's cannot be control over care. We have to be a caring, just, and universally accessible system.
So put the care in healthcare, that's for sure. Okay, Walter, recognizing the time, the equitable system of the future, what would be your take-home message?
I fully agree with Paul. Must be a universal coverage system, either based on a national health service or a social insurance, but certainly not a fee-for-service. And on a practical point of view, considering this as a public good, we have to convince politicians to invest in health and healthcare. So not considering healthcare only as a cost, but as an investment. And on a practical point of view, this means investing in prevention, in public health, engaging citizens and making citizens much more responsible about their behavior, because only 4 risk factors are responsible for 80% of the chronic disease. And also reorganizing health services. Whenever you have a universal health coverage, of course, your services must be reorganized on a population health basis. So essentially looking at the needs and demands of the population and meeting these needs and demands, rather than offering services that are inappropriate, expensive, and maybe making money for the providers. That sounds utopia. It's not.
No, I don't think so.
There is a substantial increase in part of the world where this is happening, and I hope that is going to happen everywhere.
Great. Okay, Chelsea, you get the last word.
I know we have vanishing seconds. I want to emphatically agree with everything Paul and Walter said. I also just think we all need the humility to recognize that there is no equitable health system. Like there are gross health inequities everywhere, and so I do think, to Paul's good admonition, we need to have enough kind of idiosyncrasy within our systems to really kind of target those inequities, ameliorate them, and try to obliterate them kind of, for the future. I do think, though, so often in the United States, our healthcare debate is just about coverage, understandably, because we don't have universal healthcare coverage. But I think the equating of kind of universal healthcare just to coverage really misses so much of what Walter kind of started his commentary on, that we can't not focus on the healthcare workforce. And in this country, we desperately need more well-trained kind of doctors, nurses, community healthcare workers, trained birth attendants, midwives, health techs. And we desperately need to invest in building the training capacities and the educational institutions for people to be able to kind of be educated and trained within their own communities, to be able to kind of not only provide the health care, but to certainly center the care kind of in that work and in that mission. And so I think that is hugely an important part that we don't spend enough time talking about.
Well, colleagues, I want to say in closing, thanks again for joining us for this fifth meeting. What an incredible group. And building the equitable healthcare system of the future, we all still have an awful lot of work to do. So thanks again, and ciao for now. Thank you, and God bless you all.
David.
Thank you very much.
Thank you very much.